about erythroid marrow failure, and hence, fantastic, this title. So now I don't have control of moving it forward. Can someone show me how to do that? Ah, okay, thank you. So what I plan to do today is to discuss the actual physiologies of erythroid marrow failure, to discuss our clinical approach to each of these disorders, and then some insights that come from research in cats and in mice that are very applicable to understanding why the erythroid marrow fails in people. So I'm going to start with a case. And this case is a very generic case. It could be one that any of us see at any point in time that practices adult medicine. A 62-year-old woman who had 3 months of progressive fatigue and a past medical history that's notable for rheumatoid arthritis, or a rheumatologic setting. And a physician obtains a CBC, and she's found to have an absolute neutrophil count that's normal, at 4,500, a very low hemoglobin at 6.8, platelets that are normal, and a low reticulocyte count. And of course, a marrow is obtained. And the marrow aspirate shown at the top is normal, excepting it's lacking hemoglobinized erythroid cells. And the marrow biopsy has a slight lower degree of cellularity, again, because the erythroid elements, the developing erythroid elements, are lacking. And so shown here is the way a haematopoiesis biologist looks at the marrow and blood systems. On the far left are all the cells that we can access in the blood, and why as hematologists we can actually be scientists, because we can go and biopsy with ease the cells that count and make assessments about them, or the marrow, which is shown on the going towards the left. And when you have pure red cell aplasia, there is a block somewhere along the erythroid lineage after commitment to erythropoiesis alone. And it could be at that level, or right after proerythroblast. But the hallmark is the lack of hemoglobinizing cells, erythroid red cells in the marrow. Most acquired red cell aplasia is actually immunologically mediated, as many of you know. It's usually an aberrant T cell or antibody response that targets an erythroid progenitor cell. The marrow has few or no hemoglobinized cells, and by our definition and that of many in the field, less than 10% of the marrow cells are hemoglobinizing, contain redness. And so since it's predominantly immunologic, we treat it with immunologic agents, prednisone, cyclosporin, cyclophosphamide, ATG, et cetera. One expects a CR eventually, though with each agent, it's about a 35% chance per agent. And when the CR is obtained, it's generally of long duration. And so we pick our agent based on the circumstance. Cyclosporin is often preferred in children, and cyclophosphamide, for example, in someone with coexistent lupus. It's also important to treat and identify the associated disorders such as thymoma and CLL and lymphoma to have a durable response. Now also, there's another physiology of red cell aplasia that's quite distinct, and I wanted to mention, and that's from parvovirus B19 infection. And the block is always after the proerythroblast, so that one can sometimes see, though not always, a pathognomonic finding in the marrow of a giant proerythroblast as an infected cell with parvovirus and therefore distorted it. Parvovirus has a very unique physiology, and that's the reason it's treated and thought about quite differently. It's a small, single-stranded DNA virus. It generally causes a very mild infectious disease in children, and in adults it can cause fever and arthralgia. About 60 to 70% of us have been infected with parvovirus and have antibodies against it, and will never actually be infected again because those antibodies are neutralizing and prevent the disease. Any cell that gets infected with parvovirus is lysed. It's a very active virus. And the cell that gets infected in the human body is the erythroid cell because the receptor for the virus is the erythroid P antigen. So in normal hosts, the 60 or 70% of us that have had this virus, the infection lasts 2 to 3 weeks, and during that time we have red cell aplasia. We don't make red cells. But because red cells live 3 to 4 months, it's not notable, and there's no clinical consequence. However, if it's a person with a shortened red cell lifespan, such as sickle cell disease or hereditary serocytosis or hereditary velocytosis, which you just asked a question about, and has perhaps a 5 or 7 day lifespan to the red cells, they become acutely anemic when infected with parvovirus, present with an acute red cell aplasia, and are best treated with transfusion because they'll then get over it, and 2 to 3 weeks later will be making their own red cells again. But if someone has an immune problem, such as HIV or some other immune abnormality, then they never clear the virus. Red cell aplasia develops after the 3 to 4 month time that the red cells survive, and they present pretty classically looking like a patient with red cell aplasia. But the diagnosis is important because it's not an immunologic event, and the treatment would be quite different. You diagnose with PCR, preferably a quantitative PCR, looking for the presence of virus. And very importantly, you do not use serologic studies, which are important in many viral infections because these are patients that can't clear virus, and so therefore the serologic studies would be misleading. Again, in patients with shortened red cell lifespans, you treat with transfusion. And in those that are lacking the ability to clear a virus, we give immunoglobulin, since commercial immunoglobulin, easily available, has effective antibodies that can treat this disorder. So therefore, it's important to think of it as a physiology, to diagnose it quite differently, and to treat it quite differently than immunologic red cell aplasia. And lastly, red cell aplasia can result from a congenital defect. It's termed Blackfan anemia. It's due to inherited mutations of ribosomal proteins, and I'll speak about this a little bit later, because understanding this disease, which indirectly has been something I've done in the research laboratory, has recently given us incredible insight to the physiology in general about why erythroid marrow fails, and particularly the ineffective erythropoiesis that comes from MDS. So I'm going to present case number 2 to introduce that. Case number 2 is a 4-year-old domestic short-haired cat who has 3 months of progressive fatigue. So the veterinarian obtains a CBC, and the absolute neutrophil count is normal. The hemoglobin is extremely low, and cats can actually live with extraordinarily low hemoglobins, and that's consistent with that tale of 9 lives. The reticulocyte count is low, and the platelets are normal, and the marrow shows 2% hemoglobinized cells. So this cat has red cell aplasia. And studies show that this cat has a unique infection with a virus called feline leukemia virus subgroup C. And so what's the physiology of that? And I should mention this is not a human disease, but studying cats has given us insight to understanding just plain erythropoiesis in mammalian species, including mice and humans. So the block is at the proerythroblast level. And we understand from a number of studies in my labs and elsewhere that a normal proerythroblast will express the receptor for the virus, Flvcr, feline leukemia virus C receptor, and that's an important molecule for it to complete its erythroid maturation. But in the presence of retroviral infection, the retrovirus makes a surface unit protein that binds this receptor and targets it for destruction. And so the infected proerythroblast doesn't express FLVCR on its surface and is unable to differentiate. And so knowing this a number of years ago, we wanted to go about identifying FLVCR, thinking that it was going to be a cytokine receptor and give us some new insight to the things that were important to drive erythropoiesis. So we went about doing this in an expression cloning approach, identifying first the receptor in cats and then in humans. And this is about the human. It's quite well conserved through all animal species and through all evolution. So it's 555 amino acids, 12 transmembrane domains, and a member of the major facilitator superfamily. So a transporter molecule. So it's not a receptor. Yes, it's a receptor for virus, but it's not a receptor for cytokine by structure. It's actually a transporter molecule. And then many years later, we identified that it exports but cannot import heme. So that's its function. It actually has a rather narrow substrate specificity. It also exports protoporphyrin IX and coproporphyrin, which are planar porphyrins, but not unconjugated bilirubin or bilirubirin. So that led to an important question. Over 95% of the red cell protein content is hemoglobin. Why in the world would an erythroid cell in its early development want to get rid of heme when it needed it so badly? And what I'm going to present is the hypothesis and then data that shows why, and it's given us all this insight to understanding ineffective erythropoiesis. So heme is toxic. It's important for loads of things. It's important for hemoglobin cytochromes, for a number of important enzymes, and is a signaling molecule in many processes, including circadian rhythm. It is degraded by heme oxygenase, which is transcriptionally regulated, and it could be exported through FLVCR. And so the hypothesis is at certain points in time, and particularly the proerythroblast stage of erythroid differentiation, the other two degradation approaches or use approaches aren't sufficient, and FLVCR is necessary in order to avoid heme toxicity and death of that cell. So why erythropoiesis? So people produce 2.3 million red cells a second, and we can increase that production 5 or 10-fold in stress. That's the reticulocyte count, goes up that high. Hemoglobin is over 90% of the red cell protein content, with 270 million molecules of hemoglobin per cell, each of which have 4 heme moieties. So now think of this production rate. It's absolutely huge. Erythroid precursors that are engineered to make a single protein globin and need to do it extremely efficiently and coordinate it in a time sequence with heme so that heme is never in excess. So shown here is the erythroid differentiation scheme, beginning with the BFUE to CFU to proerythroblast. And what happens is first under the influence of erythropoietin, because of the expression of the erythropoietin receptor, transferrin receptor, or CD71, is upregulated, and that allows transferrin iron to come into cells. Iron binds to IRP to induce ALAS2, which is the first and rate-limiting step of the heme synthetic pathway, and heme synthesis begins. Then heme binds to BOC1 to induce globin translation, or HRI to induce transcription in HRI to induce globin translation. And so heme is a transcriptional and translational regulator of globin that's just poised to go. And as soon as heme is there, the inhibitors are removed, and globin transcription and translation begins, and globin synthesis intensifies. But there's that time, shown here at exactly the pro-erythroblast level, where heme exceeds globin. Heme's there as a chemical, globin isn't present as a protein, and the hypothesis is FLVCR is needed to exploit it, or else cells die. Now I want to introduce one other marker, which is glycophorin A or TIR119 in mouse. Because using this marker systems, one can begin by looking at things that are transferrin receptor positive, then are dual positive, and then lost the expression of the transferrin receptor, and they're traced red cells through the differentiation sequence in the marrow. And so in order to look at this, we deleted FLVCR in mice using a conditional deletion strategy as well as a general deletion strategy, and deleted exon 3, which is the business end of the molecule. It's where the loop, that is the transport loop, is. And the prediction would be it would be a non-functional molecule even if it reassembled, which we don't think it does. And as expected, FLVCR null mice die in utero, and the red cells don't mature past the CD71 positive stage, don't continue on down the maturation sequence. Here's a control mouse with red cells in his liver, and therefore it's red, and a deleted mouse that has a very normal liver but has no red cells, and so therefore it's not red and leads to its death. And if you conditionally delete it, so in other words, you let the animal be born and then delete the gene, the animals within 4 to 5 weeks develop a very severe and macrocytic anemia, shown here with the hematocrit tubes being very low, and the hemoglobin and hematocrit being low as shown, and a high MCV. And again, they have a flow cytometry pattern, just like the ones in utero, and the pro-erythroblast death is from apoptosis. We can show very easily that heme's increased in FLVCR-deleted erythroid marrow cells, as shown here, including those that shouldn't have globin. So therefore, free heme is likely increased. But what we can't show, and it's been very difficult actually to show in the mirroring system, is whether the increased heme actually causes the pro-erythroblast apoptosis. And that led us to move to the human system to ask this question in a very different way. And those are the new and unpublished data that I'm going to share today. So here are human erythropoiesis, just like the mouse erythropoiesis. And I'm going to introduce one other marker, CD36, which more or less parallels transferrin receptor. And in the human system, we use CD36 and glycophorin A to track the differentiation of cells, just because the transferrin receptor is on later as cells mature in our vitro system. In vitro, erythroid differentiation in normal human marrow cells appears quite readily. At day 10 of culture, cells of all stages are present. And if one lets the culture go longer, they mature even further. And by day 17, they're all nicely mature CD71 negative, CD71 and CD36 negative cells that express glycophorin A, and they enucleate. And so what we do is we look at cultures at day 10, because we can divide those cultures into departments 1, 2, 3, 4, and look at the various stages of erythroid differentiation. The predictions for normal erythropoiesis would be that heme synthesis would intensify before globin synthesis, that erythroid cells might lack heme oxygenase and therefore not be able to break down any extra heme, and that FLVCR would be high and then go down as cells mature and globin is present and available for the heme to bind. And indeed, every single one of these predictions is true in the normal erythroid culture system. So shown here on top is allelyl synthase 2, which is the rate-limiting and first step of the heme synthetic pathway, and it goes up starting in the very earliest cells, and you can see heme present starting in the very earliest cells. It's well before globin is present in either form. And heme oxygenase is virtually absent, both in the constitutive and in the form that's transcriptionally regulated. And FLVCR is present early and goes on down. So all predictions hold. And in fact, this is a really good system for looking at erythropoiesis and all defects of erythropoiesis in vitro. So now I'm going to introduce 2 other human diseases that were really the clues for us: Diamond-Blackfan anemia and 5q minus MDS. So Diamond-Blackfan anemia is a sporadic and dominantly inherited congenital macrocytic anemia, and genes that encode ribosomal protein S19 or 9 other ribosomal proteins are mutated, and this always results in failed ribosome assembly. So if you don't have ribosomes, you can't translate. Globin is the only thing that's translated in erythroid cells because it's one protein. So in that speed of erythropoiesis, one cannot translate globin efficiently. The 5q minus MDS syndrome is a macrocytic anemia with high platelet counts, infrequent progression to acute leukemia, so rather stable and effective erythropoiesis. And it results from haploinsufficiency of RPS14, so another ribosomal protein, and failed ribosome assembly. And so in each circumstance, we would predict the globin translation be delayed. There'd be a longer period of time where the proerythroblast was vulnerable to heme toxicity, and that FLVCR might not be sufficient. And so that's why there's ineffective erythropoiesis and the cells die in this setting. So here is the studies of a patient with a Diamond-Blackfan anemia. And indeed, arrest occurs at the place that we expected, right between stages 1 and 2, and there's a failed pattern of erythroid differentiation. And if one looks at the numbers of cells in the early stages, they're pretty normal, and it falls off dramatically at step 2. And those cells that are actually able to make it, that are able to go from very early to step 2 in erythropoiesis, expand. So those few cells that are able to make it through the block are able to recover. And that is the clue that told us, why don't we look at two things? Why don't we look at the question of why do cells fail at step 1? And what about the cells that actually make it through? What are their characteristics that allow them to expand in step 3 and 4? Because that might first give us some insight to physiology, but also might tell us something about a way we might be able to approach therapeutically these disorders to allow more cells to escape to step 2 and then be able to expand in steps 3 and 4. So this is shown graphically now in 3 patients. Cell expansion decreases at step 1, and the heme content is actually higher at step 1, at stage 1. So that the heme being excess is what correlates with the apoptosis that we see in these patients' cells at step 1. But now the question of what about the cells that are able to survive? They're able to survive and make it to step 2 and 3 and 4. What's special about those cells that let them do it? And interestingly, the cells that are able to make it express much lower ALAS2. In other words, don't make heme, and therefore could be protected from heme toxicity, and or express much higher FLVCR. In other words, export heme more efficiently and can be protected from heme toxicity. So by looking at the characteristics of the cells that escape a block, we're able to get some insight to what that physiology of that block is, as well as looking at the steps here where we were just able to get we weren't able to get really a cause and effect relationship. These are the same studies now done in a patient with 5q minus MDS and an RPS14 abnormality. Cell expansion is very low. Lots of cells die at between step 1 and 2, as expected and as seen in the Diamond-Blackfan anemia patient. Heme content is elevated at step 1, so it correlates with that apoptosis and death. And in this particular patient, the ALAS2 was extremely low. Actually, this is the results of 2 patients. It's not just 1 patient. The ALAS2 was extremely low, so that it was making very little heme. And the FLVCR is extraordinarily high, 20-50-fold more high. So it's able to export more heme. So again, consistent with that hypothesis, or in our thoughts, actually documenting and confirming that hypothesis. To show graphically what that hypothesis is, normal erythropoiesis contains a bunch of cells, the proerythroblast stage, and those cells by chance have a distribution of the ALS2 and a distribution of their FLVCR. So some cells have more ALS2, some have less ALS2, some have more FLVCR, some have less FLVCR. And shown on the top, if you have normal erythropoiesis, all those cells, independent of how much FLVCR ALS2 are, mature and expand. So twice as many are present as one goes down the erythroid differentiation sequence. On the other hand, in Diamond-Blackfan anemia or 5q minus MDS, only those cells that are able to control their heme, in other words, those cells that either have